Hi everyone, my name is Jānis Slezins. I'm a board certified neurosurgeon based here in Riga, Latvia. Today I want to discuss with you a hot topic, which is a lumbar disc herniation. A few words on myself. I am practicing neurosurgery from 2006 when I started my training program here in Latvia. Since 2012 I am practicing neurosurgery independently as a specialist. I have had experience of working in neurosurgery in the UK for a couple of years, and now I'm back here based in Riga, Latvia. Lumbar disc herniation is one of the most common surgical diseases in the lumbar spine. Most of the people affected by this disease are middle-aged or younger. However, it's not uncommon for elderly people to have a lumbar disc herniation. In order for us to better understand what is lumbar disc herniation, we need to understand the basic concepts of anatomy of the lumbar spine. So this is the model of lumbar spine. It has 5 vertebrae, 1, 2, 3, 4, 5, which we usually call and number accordingly: L1, L2, L3, L4, L5, which L stands for lumbar. In between lumbar vertebrae there is a intervertebral disc, which is a soft, which is elastic. It's formed from cartilage. It acts as a shock absorber. Thanks to its elasticity, we can bend forwards and backwards. Each vertebrae consists from vertebral body and arch. In between vertebral body and arch there is a space which is called spinal canal. This is the place where spinal cord and nerve roots are located. Spinal cord usually ends at the level of L1, so below the level of L1 there are only nerve roots. So nerve roots are exiting spine. In between each 2 vertebral bodies there is an opening where lumbar nerve roots are exiting, and then they form nerves which are going down to the leg. So as you can see, nerve root exit site is quite close to the disc. So disc herniation or slipped disc or disc protrusion, those are basically terms that describe disc deformity. And it's not extremely important how do we call it. Is it a disc herniation or is it a disc protrusion? The thing that is actually important is this deformity causing pressure on nerve at the exiting site? It's called foraminal disc herniation or disc protrusion, and it may cause foraminal because this is foraminal opening, foraminal nerve compression. Or this can happen inside the canal, and if it's happening on the left side it will press on the left nerve root prior to exit, or on the right side. Sometimes these herniations are so big and massive that they can cause compression of both of them. So disc itself is formed from more rigid outer layer, which is called annulus fibrosus, and the inside of the annulus fibrosus there is a softer nucleus pulposus. The disc herniation is a situation when the outer layer ruptures, and through that rupture or through that opening, the inside part of the disc or nucleus can migrate out and press on the nerve root. Since nerve roots that are exiting lumbar spine are going down to the leg, compression of the lumbar spine nerve roots can cause 3 things. It can be pain, which goes to the leg. It is classically called sciatica or sciatic leg pain. It can cause numbness or pins and needles that also goes to the leg, and it can cause weakness in some particular part of the leg or foot. For example, nerve root number S1, which is leaving below the level of L5-S1, can cause a plantar flexion weakness. That means the person cannot stand on his or her tiptoes. And for example, nerve root number L4 or L5, they both contribute to dorsiflexion of the foot. So patient is not able to stand on heels. So symptoms of the lumbar disc herniation relate to the location of the disc herniation. So disc herniation can be completely asymptomatic and does not require any treatment if the disc herniation has happened in the place or location where it does not actually cause any pressure on the exiting nerve roots. And vice versa, if disc herniation has happened in the place where it is pressing on the nerves, the symptoms depend on what exactly nerve root is pressed. That means the symptoms of lumbar disc herniation relate on the location of the disc herniation and amount of the pressure. For example, if the pressure on nerve is very light, so there can be almost no pain or very light pain or mild to moderate pain or sometimes on and off pain. But if the compression is very severe, it can cause not only pain, but it can cause also weakness in corresponding muscle. Lumbar disc herniation as a disease usually develops quite rapidly, usually with sudden onset of low back pain. That is pain related to rupture of the annulus fibrosus. And once the nucleus passes through the opening and starts to pressing on the nerve, then leg pain, pins and needles, numbness, and possible weakness can develop. Usually low back pain disappears within a day or two, and more prominent, more severe, and more important becomes the leg pain. So these patients usually present to doctor's office with the main complaint of leg pain. So once we ask them, do you also have low back pain? Most typical scenarios would be like, no doctor, at the beginning I had a low back pain, but now it's gone, now it's only leg pain. Of course, there are some patients who have a chronic low back pain and they develop the disc herniation on the background of chronic low back pain. These patients, of course, can still have chronic low back pain. So when we ask them, do you have a low back pain or you have leg pain? And they say, I have both. And then it's important to emphasize and understand which one is worse. Is it leg or is it your back that hurts more? Which pain brought you here? And I usually say it's leg. Of course, back is, there is some pain in back, but that's not important at the moment. Of course, there are some patients who have already a chronic low back pain and they develop a lumbar disc herniation on the background of chronic low back pain. When we ask these patients, do you have leg or low back pain? They say, oh, I have both of them. But which pain brought you here today? Which one is more important? Which one is more severe? They will say, oh doctor, it's definitely a leg pain. Low back pain in this particular case is not that important. Regarding treatment of lumbar disc herniation, lumbar disc protrusion, or slipped lumbar disc, whatever we call it, when we treat a situation when lumbar disc deformity is causing a pressure on the nerve, we usually start treatment with conservative measures with few exceptions. These exceptions are when there is unbearable pain, which is not possible to control with any kind of pain medication, when there is a severe weakness, or when there is a so-called cauda equina syndrome, when the disc herniation is so massive that it is actually pressing on all the nerves that are located in the spine and causing not only leg pain but also sensory and motory and functional deficits in sacrum, in pelvis and pelvic organs. But that is cauda equina syndrome is a separate topic to be discussed. Diagnosis of lumbar disc herniation is being established on the basis of clinical presentation and radiological images. The golden standard of radiological images is an MRI scan, which allows us to have a detailed understanding of the anatomy and what exactly is happening, what kind of disc herniation, where it's located, what kind of nerve root it is pressing on, etc., etc. Sometimes patients already appear in the doctor's office with already performed CT scan. In most of the cases, it's possible to see disc herniation in CT scan. If it's already a very clear picture, so patient has a typical presentation and images on CT scan has a typical appearance of disc herniation, we can establish diagnosis based on CT scan as well. However, in uncertain cases, or if patient has a typical presentation but has not had any radiological images as yet, we usually refer him or her to MRI scan because it is the best option to visualize the disease. In typical scenarios, when no urgent surgery is indicated, we start treatment of the patients with conservative measures, since we know that 60 to 70% of the cases lumbar disc deformity will reduce in volumes within 6 to 8 weeks, and by doing so patient will recover. So if patient developed disease quite recently, we usually can say them quite confidently that we still have a time, let's treat you with conservative measures and let's wait for disc herniation to reabsorb or become smaller, and by that we expect you to recover. And vice versa, if patient is already complaining of this radicular leg pain for a couple of months and nothing is improving, that tells us that it's extremely unlikely that disc herniation will reduce in its volumes with time. Since time has already run out, it should have happened within 6 to 8 weeks. And that means that that patient is a candidate for surgical intervention. So there is no magic pill that we can use that will be able to take disc herniation away. Basically, when we treat patient with disc herniation and lumbar radiculopathy or sciatica or radicular leg pain, that's all the same thing, we are actually treating pain only. We are basically making patient's life more bearable, more comfortable, while we wait for the disc herniation to reabsorb. Sometimes we can, to control patient's pain, we have medications in form of tablets or injections, and we also, to improve and also for pain control, we can use injections. It's called epidural injection, which means that injection of the medication under X-ray guidance directly within the spinal canal, and it takes the swelling away from the nerve roots. Since the nerve roots which are pressed, they become swollen as well, so they kind of hurt themselves because of this swelling. So this medication, which is injected via epidural injection, which is basically medication to take away swelling. So when the swelling is taken away, nerves kind of collapse in their volumes and they become not as much pressed anymore. And by that, the symptoms can improve. Within 6 to 8 weeks, with conservative measures, with medication, maybe sometimes injections, patient should become recovered, should become healthy, back to normal. If it doesn't happen, then he or she is probably a candidate for surgical. I usually tend to say patients, so this can go in two ways, one or the other. So disc will take away itself, or if it doesn't, we will go and take it away. So if it hasn't happened, we need to go and take it away. So lumbar disc is being treated mostly by surgical intervention, lumbar microdiscectomy in typical scenarios. Surely there are some variations to the surgical technique, and sometimes there are some other techniques that we can use, like laser ablation of the disc, which is useful to some cases, but I'm now discussing the most common, most typical scenario when lumbar microdiscectomy is necessary. So what lumbar microdiscectomy is? It is a standard, quite commonly used surgical procedure, which is performed under general anesthetics. Patient is lying on his or her belly. Let's imagine we need to take away disc herniation between L4 and L5, which means between 4th and 5th lumbar vertebrae. Let's imagine we need to take disc herniation from the right side. So I will turn the model so you can see better. So that means we need to make a small incision just above the L4 and L5 interspace. So we do an X-ray just before incision to be sure that we are actually above the L4 and 5 interspace. We make an incision, we take the muscles, we retract the muscles from the spine on the affected side, which is right side in this particular case. So then we can identify lumbar laminas of L4 and lumbar lamina of L5. So we know that we need to enter this interspace. Then we do another X-ray just to make sure that we are still on the right track, that we have not deviated from the initial plan. Then this interface is covered by the ligament, which is called ligamentum flavum or just flavum. It's some kind of yellowish color. We take this ligament out, and usually we are almost immediately able to see the nerve root, especially, and usually nerve root is pressed upwards towards ourselves. So once we mobilize the nerve root, right behind the nerve root there is a disc herniation. So we take the disc herniation away. By doing that, we take some pressure away from the nerve root, and therefore we treat a patient. So when we are performing surgery, we never take away hold the disc in aggressive fashion. We usually take only the part of the disc herniation that is pressing on the nerve and so-called free fragments, the parts of the tissue that are not vital anymore, that are coming out without effort. And we never approach this aggressively, to take out the disc aggressively, because the intervertebral disc is very important structure and it should be preserved. Lumbar microdiscectomy is a straightforward procedure that lasts from 40 minutes to 1 hour on average. It's performed under general anesthetic. We usually keep patients overnight after the surgery and discharge them on the first day post-op. On the first day post-op, they are being mobilized with physiotherapists. Physiotherapists teach them to do the basics of the exercises in order to build up spinal muscles. And radicular leg pain is usually away immediately after surgery, or it can stay for a couple of hours after surgery, then it disappears. Some pins and needles can stay longer, and for sometimes they stay quite. Pins and needles and numbness can stay for quite some time, sometimes up to 9 months. Uncomplicated situations, prognosis is very good, and the prognosis is full recovery if there is no significant nerve damage symptoms prior to surgery, like weakness, for example.